Hello friends, today I am going to talk about the central nervous system tumor. This is a very important chapter. So first of all, talking about classification, there are various types of CNS tumors. One is glioma, which includes astrocytoma, oligodendroglioma, ependymoma, and next neuronal tumors, which includes ganglioma, dyserythroblast neuroepithelial tumor, and central neurocytoma. Then third type is poorly differentiated neoplasms, which includes medulloblastoma, rhabdoid tumor, also known as atypical teratoids, and other parenchymal tumors include primary CNS lymphoma, germ cell tumors, spinal parenchymal tumors. Fifth type is meningiomas, and last is metastatic tumors. So now we will talk about gliomas basically in this video. So gliomas are the most common group of primary brain tumors. They have characteristic histologic features that form the basis of classification. There are, however, as it is true of many hematologic malignancies, it appears that these tumors are derived from a multipotent progenitor cell that preferentially differentiates down the particular cell lineage. So astrocytoma doesn't mean that it arises from astrocyte. It means that it differentiates into some part astrocytes. Some multipotent progenitor cell will preferentially differentiate into astrocyte. So glioma includes three types of tumor: astrocytoma, oligodendroglioma, and ependymomas. Today we will talk about astrocytoma mainly. First of all, talking about astrocytoma, there are two major categories of astrocytoma. One is infiltrating astrocytomas, which usually ranks from group WHO grade 2 to 4, and pilocytic astrocytoma is WHO grade 1. More less is the grade, more is it is more benign is it. We will talk later about this. Infiltrating astrocytomas WHO grade 2 to 4. They account for 80% of primary brain tumor in adult. In which side they are present? They are usually found in cerebral hemisphere. They may also occur in cerebellum, brainstem, or spinal cord. Infiltrating astrocytoma, WHO grade 2 to 4. It includes. Is most common, often in 4th to 6th decade. The degree of histologic differentiation of infiltrating astrocytoma correlates well with clinical outcome. The tumor ranges from diffuse astrocytoma grade 2 to anaplastic astrocytoma grade 3 and glioblastoma grade 4. DAG 234 DAG. D for diffuse astrocytoma, A for anaplastic astrocytoma, and G for glioblastoma 234. The grade 4 further is stratified based on mutation of the isolated dehydrogenase gene IDS1 or IDS2 into IDS mutant and IDS wild forms. The former is associated with considerably better prognosis than latter. IDS mutant has better prognosis than IDS wild type. There are no WHO grade 1 infiltrating tumors, infiltrating astrocytoma, because they are considered malignant by definition. WHO grade 1 includes pilocytic astrocytoma. We'll talk about this later. That is benign tumor. So this is picture table from Robbins. WHO grade or anaplastic astrocytoma. WHO grade 2 to 2 or 3, which is mutant. IDS as a mutant. Glioma IDS WT is wild type. Remaining all are mutant. And there are various genetics and all this. First of all, talking about diffuse astrocytoma, that is grade 2. Grade 2 astrocytoma. So what is the gross appearance of diffuse astrocytoma? They are poorly defined gray infiltrative tumor that expand and distort the involved brain. Size, they range from few centimeter to lesion that replace nearly entire brain. So there, it may be very small to very large, which may even replace entire brain. They are poorly defined, gray and infiltrating. Diffuse means you can easily derive from the name itself. They are poorly defined. Gray infiltrative, diffuse. They are diffuse means poorly defined, gray infiltrative tumor. The cut surface of tumor may be either firm or soft and gelatinous. They have gelatinous texture. Cystic degeneration may be seen. The tumor may appear well demarcated, but it is more commonly ill-defined due to infiltration beyond the perceived margin. You can see here picture of the diffuse astrocytoma or the right frontal tumor. Right frontal tumor expanded gyra which lead to flattening. There is bilateral expansion of septum pellucidum by gray glassy tumor. You can see here, this is septum pellucidum, and this is glassy, gray glassy tumor. Bilateral expansion of tumor. This is picture from Robbins 937. So talking about microscopy of diffuse astrocytoma, they have cellular density that is greater than normal white matter. Between tumor cell nuclei, there is an extensive fieldwork of fine GFAP, glial fibrillary acidic protein positive, GFAP positive astrocytic processes that create a fibrillary background appearance. There are variable degrees of nuclear pleomorphism. The transition between neoplastic and normal tissue is indistinct, and tumor cell infiltrate normal tissue some distance away from the main lesion. So you can see here, this is neoplastic astrocyte, and they have GFAP positive fibrillary background. You can say this is fibrillary background. You can see in histology, this is neoplastic astrocyte. Microscopic appearance of diffuse astrocytoma. They have greater cellular density than corresponding white matter. Again, this picture is from Robbins 10th edition. This histologic section from white matter shows enlarged irregular hyperchromatic nuclei that appears embedded within native fibrillary matrix of the brain. You can see this is some hyperchromic nuclei. Enlarged nuclei is appear to be embedded within fibrillary background. You can see here immunohistamine for IDH1R132H is positive for mutant protein in tumor cell, some of which surround the large immunonegative cortical neuron, perineuronal cellulosis. So talking about next type, anaplastic astrocytoma. They are more densely cellular. They have greater nuclear pleomorphism. Mitotic figure are often observed. This is the main point. You can remember. Mitotic figure are observed in anaplastic. They have greater nuclear pleomorphism. The term gematocytic astrocytoma is used for tumor in which the predominant neoplastic astrocyte shows a brightly eosinophilic cell body from which emanate abundant start process. Glioblastoma. It was previously called glioblastoma multiforme. Gross appearance, it varies from region to region. In some area it is firm or white, in other it is soft and yellow due to necrosis. Some others show cystic generation and hemorrhage. You can see here. Contrast T1 weighted coronal magnetic resonance MRI image shows large mass in the right parietal lobe with ring enhancement. You can see here. This is glioblastoma. What do you mean by T1 weighted? Do you know? Remember from anatomy? In T1 weighted MRI, the liquid is seen in dark color and fat is in bright color. So you can see here in right parietal lobe, you can see here glioblastoma. Glioblastoma appearing as necrotic, hemorrhagic, infiltrating mass. Talking about microscopy, the histologic appearance of glioblastoma is similar to anaplastic astrocytoma with the additional feature of necrosis and vascular endothelial cell proliferation. So again, listen again. Glioblastoma means anaplastic astrocytoma plus necrosis. You can remember in easy way. Glioblastoma is equal to anaplastic plus necrosis. Necrosis. Necrosis in glioblastoma often occurs in serpentine pattern in areas of hypercellularity. The tumor cell collect cases of necrotic region, producing a histologic pattern referred to as pseudo. This is very, very important. Vascular cell proliferation produces stuffed up cells that pile up and bulge into lumen. The minimal criterion for this feature is a double layer of endothelial cell. With marked vascular cell proliferation, the tough form of ball-like structure, the glomerular body. Marked vascular cell proliferation, the tough form of ball-like structure, the glomerular body. So you have to remember this key point in this glioblastoma. Pseudo-palisading serpentine pattern of necrosis, vascular cell proliferation, and glomerular body. You have to include these 4 points in your answer. VEGF produced by malignant astrocyte, vascular endothelial growth factor, in response to hypoxia contributes to this distinctive vascular changes. Since histologic feature can be extremely variable from one region to another, small biopsy semen may not be representative of the entire tumor. So you can see an easy diagram. This is the area of necrosis. Small poorly differentiated tumor. You can see here small poorly differentiated tumor, area of necrosis. These are areas of necrosis. Pseudo-palisading of tumor cells around the area of necrosis. Pseudo-palisading of tumor cells. You can see here pseudo-palisading tumor. Tumor cell collect along the edges of the necrotic region, producing a histologic pattern referred to as pseudo-palisading. Tumor cell collect along the edges of necrotic zone, producing a pseudo-palisading structure. This is endothelial cell proliferation. They will form tough-like ball-like structure, the glomerular body. So finally, talking about pilocytic astrocytoma. It is dubbed as a grade 1 tumor, distinguished from infiltrative astrocytoma by their more discrete borders, unique histopathologic and molecular characteristic, and relatively benign behavior. They are benign. Age, what is age? They typically occur in children and young adult. Infiltrating astrocytoma used to occur in which age? 40 to 50th decade. But here it is pediatric brain tumor, pilocytic astrocytoma. Site is usually located in the cerebellum. May also appear in region around the third ventricle, optic nerve, spinal cord, and occasionally in cerebral hemisphere. Diffuse astrocytoma used to occur mostly in cerebrum. Pilocytic astrocytoma mostly occurs in cerebellum. The histologic separation of this tumor from other astrocytoma is supported by the relative circumscription, unique histopathologic features, and distinct genetic alteration of the MAP kinase pathway. The most common being a KIAA1549 BRAF gene fusion duplication. You may not need this genetic details. Pilocytic astrocytomas go very slowly and can often be treated by resection alone. Symptomatic recurrence and incompletely resected lesion may be treated with repeated surgery, chemotherapy, or targeted therapy. GRUS. Pilocytic astrocytoma is often radiologically and grossly well demarcated and cystic, with a contrast enhancing mural nodule. What is the gross appearance? It is radiological and grossly well demarcated. It is well demarcated and cystic, with a contrast enhancing mural nodule. You can see here, grossly this cerebellar tumor form a mural nodule within the cyst. Let's see radiological picture now. You can see here, cyst with mural nodule. This is mural nodule, cyst. Talking about microscopy, histologically it differs from infiltrative astrocytoma of any grade by showing only limited invasion with often biphasic architecture combining loose microcystic and compact densely fibrillar areas. So, pilocytic astrocytoma has biphasic architecture. Biphasic architecture means they are both loose microcystic and compact densely fibrillar areas, dense fibrillar areas and loose macrocystic area. They are biphasic architecture. Remember this. The tumor is often composed of bipolar cell with long, thin hair-like processes, GFAP positive, and form a dense fibrillary network. They have a bipolar cell with hair-like process that are GFAP positive and form dense fibrillar network. Rosenthal fiber and eosinophilic granule bodies are characteristic finding. Rosenthal fiber and eosinophilic granule bodies. These two are a characteristic finding. What do you mean by Rosenthal fiber? Rosenthal fiber means eosinophilic cork-shaped inclusion. Eosinophilic cork-shaped inclusion. Eosinophilic granular bodies means mulberry-like inclusion. In contrast to diffuse glioma, the presence of microvascular proliferation of or necrosis doesn't imply an unfavorable prognosis. You can see here, at low magnification, one can appreciate atrophic cerebellar cortex top, sharp circumscription, and biphasic pattern with alternating loose and compact bottom region. Loose and high magnification reveals oval to irregular tumor nuclei resembling those of diffuse astrocytoma, but with numerous Rosenthal fiber, brightly eosinophilic cork-shaped inclusion in background. So these are all about astrocytoma.